All right, so you're recording.
So it's at the top. Okay.
And I can always edit the video afterwards for like this part because we're actually recording audio right now.
It's just you and me.
So
Okay.
far.
Oh, okay. That'd be great if you could edit it out. That's perfect.
Just let me know when you're done.
Okay,
and,
perfect.
I'll grab it.
Okay, thanks so
Just
much,
make sure you want
Blake.
this closed.
Yes, thank you.
And I should be in my office.
If you have any trouble, I'll just say, Blake, can you come?
Yeah.
Okay, perfect.
Yeah. I'm muted, but I'll be listening.
You'll be able to hear it. Okay, thank you so much. Yeah, perfect. Yeah, thank you. Hello, this is Jenny. Hi, Courtney. How you doing? I'm good. Oh, well, I thought the meeting was already started. So let me, I have another co-host, Blake Humphrey, who's helping me. So I will just let him know. Blake, there's somebody trying to join the meeting and it says I haven't started the meeting yet. So if you could help me with that, that would be great. Sorry
Sure.
about that,
Send me
Courtney.
their email address.
What was that?
Can you send me her email address?
I will do that. I will do that. Hold on.
Or just give it to me. That works too.
Okay, Courtney, can you just tell me your email address? It's CHULTETT, sorry, at lakeregional.com.
So I have like CHULETT at lakeregional.com.
That's correct. And then the other person that's going to be joining us is Steve Norman. And his email address is steve.norman at rehabvisions.com. Is that right, Courtney? .com.
And is Norman Norman?
Yes, correct. And then Kevin probably let you know, but he's not feeling well today, so he's not going to be able to join the meeting.
All right, I just emailed both of them the link to the meeting.
Okay, perfect. Thanks, Blake. So, Courtney, you should be getting a link to the meeting. Yeah, I think, see, Blake, he's already in Zoom, but it's just saying it's waiting for me to start the meeting. So should he close the Zoom out and link, click on the link you're sending him?
Yeah. The link that I'm sending, if they just click on it, it'll automatically bring them into this meeting.
Okay, so if you click on the link, and you'll be getting an email from Blake Humphrey. So you can close out of the one you're in, and just click on the link that Blake sends you. Yeah, join from PC, is that the one, Blake?
In the link that I sent?
Is it in the link that he sent you? Yes.
This is kind of fun. It's like playing a game of telephone tag.
I should.
Yeah, it should. Let me get to it. I don't know before
okay, now I put Courtney on speaker, so we don't have to repeat everything.
I don't know. Phone tag was kind of fun. Yeah, so the link that I sent should say join from PC, Mac, Linux, iOS, or Android.
Yes,
It has
yes,
the
join
URL.
from PC.
And you just click that one. Oh, we got 3 participants now.
Oh, that's good. Is that you, Courtney?
It is.
Okay. So I'm going to hang up so we don't get all. Yep, he hung up. So that's good. So Courtney, you want to talk so I can make sure I can hear you?
Her mic is muted.
It's okay. So Courtney, I think your mic is muted.
There, I've unmuted it.
So Courtney, can you try talking to see if we can hear you? Not sure if you are trying to talk, but we're not hearing you.
I don't see any activity on her microphone. So her microphone might be muted on her computer.
Okay, so Courtney is a male.
Oh,
But
is?
yes,
Sorry.
that's okay. So Courtney, if you could check to see if your microphone is muted on your computer. We're still not hearing you if you're trying to talk. We are showing that there's an additional participant, so I'm assuming it's you.
Yeah, it says C. Hewlett or Chulet.
Yep, that's Courtney. Yep.
There's also a chat function in Zoom. So if people, we've had this before where people's microphones on their personal device wasn't working. As an alternative, Courtney could call in. I can hear you. Okay, great. We can't hear you. So either your mic is muted or you can just use this chat function.
Okay, so now, Blake, I'm not seeing the chat. I remember.
Yeah. I'll come show you here in
Okay,
a second.
thank you. Sorry for the delay, Courtney, but we'll wait for Steve to join anyway, if that's okay with you. Oh, maybe I have to look at annotate. Is it the annotate?
No, if you go ahead and click on the more.
Oh, the more. I always forget more. And then chat.
Yeah.
Okay, great. Courtney, now I know how to see, and I'll try to keep an eye on that in case you have questions as we go along. But I think I would like to wait until Steve joins since it'll just be the 3 of us. Is that okay with you? Can you still hear me, Courtney? Okay, great. So once Steve joins, then we'll start the webinar, okay? This or
Yeah, so part of the issue is that when you minimize that.
I'm not going to be able to see.
Right.
Yeah.
But
So,
they can't see it right now. All they can
okay.
see is the PowerPoint.
Oh, okay. So
So
if
you
I
could-
just put it somewhere where I can.
Yeah, you might be able to make it smaller, like from the side.
Oh, yeah.
If you grab it.
That's pretty good. Because I have my, yeah, that'll work.
That'll work.
Yeah.
You could also not do full screen. So if you go up here to more again. This is different than mine. Maybe it's because you're presenting.
Yeah. Well, I think this will be good. And then,
Once you're in there, then it takes it away. So you have to go up and then physically go chat. So it's not really.
yeah, so I think I better have it on. Because in case you can't, so how do I get it back? Go back in there?
You have to go back up to the top.
More and chat. Okay. Oops. Okay.
Smells enough to go.
Lost it. Let me just check my cell phone and see if Steve has.
We got fourth.
Can you hear me?
Oh,
Yeah.
yes, I can. Hi, Steve. How are you?
This is Steve.
Great. So, Steve, we have myself and then a colleague of mine, Blake Humphrey, that's helping us with the technology piece. And then Courtney is here as well, but Courtney's having trouble with his mic. So he's going to be communicating if he has questions or comments through the chat function. So since you are able to, and we're able to hear you, then it's fine for you to, if you're comfortable, just talking instead of chatting through the.
That's fine. That's fine.
Okay. So
sorry, I'm late. I guess I came in, but the number wasn't quite right, so I just went back up again.
Courtney had the same issue, so I'm glad everybody's on now. Unfortunately, Kevin is not feeling well today, so he's not going to be able to join.
Oh, that's too bad.
I don't think Bill is going to join either. We are going to record this session, so and we'll be able to edit out all of this that up until this point, so that if you want to share this with any of your staff that would be potentially working with the intern, or anybody on your staff that you think could benefit.
Can you guys hear me now?
Oh yeah, we can. There's a little bit of an echo, but. Yeah, there's an echo.
Should be better now.
Yeah, that's better.
Okay.
Perfect. Okay, excellent. So,
Hi, Steve.
Howdy. How are you doing?
Good.
Good.
So we're going to be able to edit all of that out of this recording, and then you can use it with your staff, whoever you think would benefit for this. And I wanted to just start out by thanking you for taking time, because I know you're both really busy. And because of this platform, it's mainly going to be me sharing information, but because it's so small, just the three of us, obviously there will be plenty of time for questions. And even if it's questions that are related, but not things that I'm covering today. So really the purpose of this is just to make sure that you both, and then people from Rehab Visions, feel comfortable with this year-long internship. So I know it takes just time to kind of process the whole concept. And so one of the things we'll start with is just reviewing the model and making sure that you have all of your questions answered. Then we'll talk a little bit about, let me just go to the next slide here. There we go. And then we'll take some time to talk about the similarities and differences in the role of the clinical instructor versus a mentor. As the student progresses through the experience, it will become more of a mentor-mentee relationship versus a traditional clinical instructor-student relationship. Then we'll talk about some suggestions on how you might structure the experience. And we know that this is going to be different from site to site, even from your within Rehab Visions. It might be a little bit different from location to location. And then I'm going to share some tools with you that the mentors might find useful in trying to facilitate ongoing professional development and reasoning as the year progresses. So to start out by just reviewing the model and sharing again what our rationale was in moving to this model. So there is a pre and a post-graduation phase of the year-long internship. And the focus in the pre-graduation phase is no different from a final clinical experience. So really the focus there is to make sure that the student develops that entry-level competency so that they're ready to practice by the time that they graduate. And that's really what the focus is, to really help them develop those entry-level skills. In the post-graduation phase, it's really more of the intangibles, helping the intern really develop as a professional in that first year of practice so that they're ready for the demands of the changing healthcare system. And so some of the things are confidence, self-efficacy, really embracing the full role of the professional that they may not have fully refined in the pre-graduation phase. And what we really believe is that this can only happen through ongoing mentoring and a structure to the experience. And so I'll be talking about ways that you might consider how to do that. And this is based on the work of Lisa Black and her colleagues. And that she really did a qualitative study, and I'm not sure if you had a chance to read that over that article, but basically she and her colleagues identified that learning within a community of practice, and so each of your settings are a community of practice with all of the staff, not just in the physical therapy department, but throughout the whole hospital or clinic, including patients, is where we really learn and develop in that first year and really become socialized as a professional. So this structured experience will allow the intern to develop more proficiency, confidence, so that they're really ready. So in that, just to highlight some of the key things from that article, at the center or the core is really where the intern or the professional develops that professional identity and is able to transition from the role of a student to the role of professional physical therapist. And that's one of the reasons we went to this pre and the post-graduation phase of the model, because we feel like sometimes students are sheltered from some of the more complex, even maybe potentially undesirable aspects of practice because of the support that they get from their clinical instructor. And when they're fully licensed, it really kind of the buck stops there. So we really believe that in that post-graduation phase is where they can really develop. And what this takes is being a part of a community of practice and receiving the support that they need as a new professional, learning through experience. So a bulk of what they're going to be doing is actually working with patients because they need that repetition of an exposure to a variety of patients to be able to develop more proficiency. In the clinical environment, what we learned, the other thing I'm going to do as we go through is, I think I shared with you that we were able to pilot the experience at our University of Colorado Hospital with just 2 interns, but we learned a lot from doing that, and I'd like to share some of the things as we go through. One of the things that they learned was from the interns, this is feedback that they gave us, was the importance of having everybody, even people that aren't directly working with them as the intern, to understand the internship and how it's different than having a student for a year. So one of the things that we'll recommend is that you make sure that in addition to whoever is directly mentoring the intern, all of your staff is kind of understands the internship model. So the goals and the expectations, our rationale really is to create a community of practice that will allow the intern that progression of responsibility and skill across the year and allow a more seamless transition from the role of student to the role of new professional. So really providing that continuity of professional development so that it doesn't stop at that entry level, but transitioning to the full, that first year of practice. So we have a sense of what entry-level practice is. We have a definition from that clinical performance instrument that most programs use to evaluate students during their clinical education experiences. And this is just a description of that, where by the time a student graduates, they should be capable of maintaining 100% of a caseload that you would expect of a new grad, that they're able to do that without guidance or supervision for both simple and complex patients. They're pretty proficient and skilled in simple and complex patient care, and they know when they need to consult with others. So, and this, there's a lot of variety across the country in terms of the length of the final clinical, but one of the reasons we feel that the students need that 16 weeks is that there is variation in how fast or slow students progress. What we find is that most students reach that entry-level practice, the basic kind of minimum competency, at about 12 weeks. But we do have some students that need the full 16 weeks to meet that. And we want to make sure that even though they're continuing in this year of mentor experience, that they are at that minimal competency level by the time they graduate. Now, in the CPI, there is a definition for beyond entry level, but it becomes a little more nebulous in terms of when students reach this point. So we haven't really defined it clearly of whether this happens in 3 months, 6 months, a year, or longer. Now, being managers in your sites, you probably have a sense of how long it takes a new grad to reach this level. But as a profession, we haven't really defined that very well. But the beyond entry level point is, that they're beyond being able to manage 100% caseload, but they're really now at a place where they're contributing to the facility. They're maybe capable of supervising others. They're able to work without guidance for simple and highly complex patients. They're highly skilled at this point, and they're able to function in inferior situations. So again, not sure when that happens, but what we hope is that at some point in that transition over the year, that all of our students, our graduates, will be functioning at this proficient level. Now, we have, as a profession, thanks to the work of Gail Jensen and her colleagues, identified a trajectory towards expert practice. And I don't want to imply that the internship is going to result in the student becoming an expert after this year, but we feel that it will help to kind of fill that gap between where they are when they graduate and if they're going to move beyond their professional development and consider residency or fellowship training, that this internship is a great way to fill that gap. And then we feel that they'll actually be better prepared to enter residency training than our new grads will be. So the Dreyfus model of skill acquisition, I don't know if you guys are familiar with this terminology, but we found it to be helpful in helping us kind of wrap our heads around more specifically where we want this intern to function at. And we think this will be a good tool for the mentors to use in terms of monitoring progress over the year. And it really looks at, the focus is really on the critical reasoning piece. So that as a novice physical therapist or professional, and this is actually out of the nursing literature, but it is used in some residency programs to help the resident move across that continuum. But as novice therapists, we tend to follow specific rules to help make our clinical decisions. We consider all the information, and sometimes we don't necessarily know what we don't know. And as you move towards expert practice, you use a deeper level of clinical reasoning. You can, because of the clinical experience that you have, you're able to base some of those decisions on your intuition. You are able to focus and just on the relevant information to help you make your decisions. And metacognitive ability is really your ability to think about your thinking. So at this point, you're very comfortable with knowing what you don't know and how you might go about filling in the gaps of any knowledge that you're missing. So this is back to the Dreyfus scale, the novice to expert scale. And this, I failed to mention that I will send you a copy of this PowerPoint, or we'll be posting this on our website for clinical instructors so you can access this later. And in addition to that, you'll have access to these tools. So this will be you can download it and use it in your clinic as well. But you can take a few minutes just to look at the description or characteristics from novice to expert practice. And I think you'll be able to visualize people as they progress through this development. So what I find interesting is that we expect our students to be competent at that entry level point, or that's what we describe it as, by the time that they graduate. And if we look at medicine, that really they don't expect medical students to be at the competent level. They expect them in their fourth year to be at the advanced beginner level, and they don't really expect competence until their first year of residency, post-graduation. And they don't expect proficiency until year 3 of post-graduation. So I think this speaks to that disconnect or gap between where we say students are at the end of their formal education and where they really need to be in clinical practice. And that's, again, one of the reasons we think this internship will be really important. So again, that expert practice, again, just highlighting what some of the differences in their reasoning practice are, and or reasoning process. And again, we don't expect these interns to be experts, but we do believe through mentoring and structuring the experience that they can move along this continuum towards expert practice. So an expert's reasoning process, the patient is at the central of the process, and they use a very collaborative problem-solving approach. So rather than just telling a patient what they need to do, it's more collaborative. They extract information from the patient and problem solve together. They use a more intuitive reasoning process, which is much quicker than following all the rules and having to do all the special tests to come up with what the problem is. And they spend time reflecting on their reasoning. And reflection is going to be a really important part of this intern's development over the whole year. And that's really how experts become experts, is they don't just repeat the same thing over and over, but they really reflect and refine, and they're really curious about how patients respond to their care. So Margaret Plack did a study as well to talk about how we move people from novice towards expert development. And it does take learning within a community of practice. So all of your staff, that creates that community of practice along with patients. And in order for them to move along that continuum, they must engage with patients, engage with all aspects of practice, the good, the bad, the ugly. So at that point, and even it can happen before graduation, but certainly after graduation when the intern is licensed, they won't be shielded because they need to produce for your company, and so they have to be able to manage those difficult situations. They learn through observation and reflection, and they really need to participate in a lot of discussion, because this leads to more of a shared understanding and shared meaning of the experiences that they're participating in. And I think the role of the clinical instructor and then on to the mentor is to help the student intern to accurately self-assess their strengths and the areas that they still need to work on. So just to reiterate kind of the necessary skill set that we feel the internship should focus on in helping the intern develop. Obviously, they're clinical skills. So if you think back to your first year of practice, a huge learning curve on just refining your clinical skills because of the repetition that you had the opportunity to have. So a bulk of this internship will be spent on patient care. Another area that we really feel needs to be developed is that clinical reasoning and the professionalism of that full professional fitting into your interdisciplinary teams. Lots of self-reflection and assessment, and then the focus on developing habits of lifelong learning. So for that to take place, obviously a necessary ingredient is time. So it does take time to work with patients. It does take time of the colleagues for the intern to be able to discuss and debrief after difficult situations, and then time in self-reflection. So that's kind of a quick overview of the year-long internship, and I thought I'd pause there to see if either of you have any questions about the model or kind of the rationale or what the purpose of the internship is. And it can be, even if it's not related to exactly what we've talked about, I want to make sure that I'm meeting your needs.
Well, I do have a question related to, just the year itself, and you're kind of splitting it up into the pre-graduation and post-graduation times. As I understood it, there was going to be a more traditional internship, 4 months long or 3 months long, after which then the student goes back to Denver to graduate. Is that right?
The graduation will be in Denver. We actually do hope they come back for graduation, but we understand that, we're not going to make it mandatory because of the travel costs involved, but we're hoping that they would want that closure. And
When
so
is that?
the pre-graduation phase, it starts at the end of August and then officially ends December the 13th. And that allows a couple days to travel back to Denver for those who are out of town and be able to participate in graduation on December the 16th. Then they would go back to their site and continue on until August of 2017.
Okay. So just in the planning stages, we would need to plan for at least a week-long or 10-day long vacation in December.
Well, that we're leaving that up to the sites, but one of the things that might help with is, because I know Rehab Visions, you're going to start the payment in the post-graduation phase after they're licensed.
Yeah.
And they really can't continue on working in the capacity that a student physical therapist can once they've graduated. So, and there will be a gap. We're going to try to obviously minimize that gap by having them take their licensure exam prior to graduation, so that once their final transcripts are sent to the board, that will minimize that gap time of them becoming licensed. But nevertheless, there will be a little gap in there.
When is the test?
The test is in October, end of October. And I am not sure, Steve, about Washington, whether or not students are allowed to take the exam early. If they're not, they could go to a state where they could do that, or they could come back to Colorado to take the exam. But then they're going to have to get reciprocity for licensure. So do you know if they're able to take the exam early in Washington? And I can look that information up as well.
I'm not sure.
Yeah.
I think they stick to the dogmatic so many times during the year. And
Right. So there is an October date, which would be the pre-graduation. There is also then the next set date is January.
yeah, I think they allow it. It's just the licensing in Washington. The board is very slow.
Yeah, that's a challenge.
It takes a while for them to decide and get everything through. So.
Mm-hmm. So one of the things that we'll do on our end, and you can also reinforce this, is to make sure that the students have all their ducks in a row.
Yeah.
To minimize that time, so that they have all their paperwork in, that it is a matter of just getting that information to the board so that they can deem their license.
And then, okay. And we've kind of made the practice of not hiring somebody until they've actually been licensed, where you don't.
Yeah, that's what Bill was sharing with me as well. That's sort of a facility organization.
Yeah. And I don't know, Courtney, do you do that too? Do you work with anybody on a temporary license?
We do our best not to. I mean, I don't know that it's written policy, honestly, but I know that it's, like you kind of said, it's a Rehab Visions practice that we've gotten burned on that before in the past, and we try not to do that most of the time.
That's what Bill explained to me as well, and I think he clearly made that pretty clear in the information that he provided to the students.
Sure.
So I think that they are aware that they need to take the license if it's possible. And I think in Missouri, when I was visiting Courtney, I'm pretty sure maybe it was Kevin or somebody told me that you can take it early in Missouri.
Kevin would probably know that. Yeah, so he deals with the students more. What are your thoughts on the anxiety maybe that's involved with taking the test and working full time, basically?
That's a great question, and based on our experience, there are some students that may choose not to take it early because of that very reason. And I don't think we can force a student to take the exam early, but highly encourage them to. We have purchased the PEAT exam, which is a practice exam that looks very similar to the actual exam, and we have purchased that for our students. So they will be able to take practice exams that are very similar to the actual exam, and it will give them an idea of where their strengths are and where they may have deficiencies so that they can really focus on those deficiencies. We will send the message that their primary focus needs to still be on their clinical experience, which in the past we've actually had a capstone project that they had to complete during their final clinicals, in addition to some students also studying for exams. So I think it's an individual that some students are going to be more anxious than others. We're going to try to prepare them as best as we possibly can and provide those resources for them. And I guess and I'm pretty sure what Bill recommended to the students is that they do take that exam early, because he doesn't want to do the temporary licensure either. He really wants, like you said, he wants them to be licensed.
Yeah, I guess I'd have to look it up to see whether or not they can take it early, but otherwise, yeah, it sounds fine. I just wanted to get kind of a timeline as to what to expect.
Yeah. Any other questions about the model?
I think the model sounds very sound. I think we all hope to live by that.
Yeah, excellent. Yeah.
Jenny, I had the pleasure of meeting Amanda and Deanna yesterday.
Yeah.
Spent about 3 hours with them.
Oh, that's excellent.
And I was very impressed with both of them. But one question that came up as we talked was, as you said, the time factor. And they were, and I apologize, I have not had a chance to go through the information that you sent earlier this week.
That's okay.
They were a little, they questioned, I guess, how much time would be set aside weekly for the mentoring process.
Yes.
And I kind of reassured them that, we can, if we have to do 3 lunch hours or whatever, but the expectation they brought was a 1 to 2 hour a week. Is that correct?
Well, that's not exactly. I mean, we are saying to the sites that they can do that. It's kind of accurate, and we're going to be getting into that, but I'll just answer that now.
Oh, okay.
In the pre-graduation phase, it will be very similar to how you set up your clinical experiences. And so the clinical instructors, I know they spend a lot of time mentoring the students. In the post-graduation phase, what we're recommending, and it's based on our pilot with University Hospital, they set aside 4 hours per week. Now, this was not 4 hours per week sitting with the mentor. So it may be 1 or 2 hours that they're with the mentor, but it might not even be 1 or 2 hours every week with the mentor. It's really going to depend, and I think Bill kind of got this concept on the relationship between the mentor and the intern. And Bill said, I would not have wanted to meet with somebody every week. Once I'm graduated, I want to kind of spread my wings. So it will be individual in terms of that, but we do want sites to plan, and this is why you're paying a lower salary than you would a new grad. But you're taking into consideration with that pay that there will be potential lost productivity time for the mentor. It may not, it shouldn't be 4 hours per week, but it may be that the intern is spending time looking up information on, let's say they have a patient that they've not worked with anyone with that diagnosis before. So there would be time built in for them to maybe look up information. The mentor time, we would, that could be on a weekly or a bi-weekly, and then as the internship goes on, maybe it's every other week, maybe it's once a month, depending on how the person is developing and progressing. But that time could be actually the mentor observing the intern treating a patient, or the intern observing a mentor treating a patient, or co-treating, or a debriefing about a patient, talking about bigger things than in addition to patient care, but just, maybe it's about communication strategies for a family that's having difficulty, or, those kind of things. So, but what worked well at UCH was actually blocking off the schedule for different activities on a weekly basis, because we all know if it's not structured, then the tendency is going to be those hours will get filled in with patient care. And the other thing is that they were very clear with the interns that sometimes their temptation was to use that time to catch up on their documentation, but that we don't want that to happen either, because they'll become more efficient with their documentation, but you shouldn't be blocking time off for them to catch up, if that makes sense. So
Sure.
We'll talk about some of the ideas for learning activities a little bit later. But,
Okay, perfect.
But yeah, I think if you can think about, blocking off 4 hours per week, and then the mentor, it might be meeting with them 1 to 2 hours every week or every other week initially, and then that may taper off, or it may be that it works better for them to have a half day sometime once a month, so it can be a little bit flexible. But the mentor time would be included in that 4 hour per week. Does that help?
Yes, thank you very much.
Great, sure. Anything else from you, Steve, about the model?
No, I guess sometimes, mentoring, scheduling time away, just sitting and discussing things. Do you feel that there are times with co-treatment and so on as being a mentorship, or a portion
Yes,
of?
I would consider that part of mentoring. Yes, absolutely.
So you don't necessarily avoid the patient care, yet you still have the time to consult and.
Right. So the patient care, once they're graduating, because in the pre-graduation phase, they should have demonstrated that they're capable of carrying a full caseload.
Right.
Because that's what they have to do by graduation.
Right.
And in the post-graduation phase, the ongoing mentoring that can take place by carving out that time. And so it could be 4 hours a week on the intern's time, but on the mentor time, it might be 1 hour.
Right.
Or maybe it's 2 hours every other week. Or maybe it's, it's just going to kind of depend. But the rest of the time, the 36 hours will be spent in direct patient care, because they do need that repetition and opportunity to develop their clinical skills and their reasoning with actual patient care.
I think sometimes too with mentoring, it's nice to not only just take what the student has as far as questioning, but if you have a particularly interesting patient, you draw them in to assist you.
Exactly. That's
Okay.
exactly right. Yep.
Okay.
Okay.
Thank you.
Sure. Okay, so now we're transitioning to talk about the role of the clinical instructor, which I'm sure you're very familiar with, and then we'll kind of contrast that with the role of the mentor, which is maybe not so well defined in physical therapy as it is maybe in some other professions. But the role of the clinical instructor, and especially during this particular clinical experience, that final terminal internship, is to help develop the entry-level clinician. So really thinking about what this person needs to get there. So it's setting goals and helping the student intern plan. It's determining their learning needs and helping to design learning experiences. It's also evaluating their performance and providing feedback, and then continuing to challenge them along the way. And as I mentioned, most of our students meet the entry level by month 3. But it then gives them the opportunity in that last month to really develop some proficiency before being totally on their own. And what we found is that if they do meet that entry level mark by the end of month 3, that because there's so much emphasis on being able to carry a full load, that in some instances the tendency might be to just let them be on their own. But we also want to remember that that's still a learning experience. And so this is continuing to challenge them in that final month is going to be really important to set them up for success in their post-graduation phase. So that's the time where you both have wonderful breadth available. So it may be, once they've demonstrated that they've met the criteria that we want them to meet, maybe that's the time when they get to explore other opportunities that you have for learning across your settings, or be with specialists, or really continue to challenge their thinking. It may be a time when they go back, and even though they're independent, the clinical instructor steps in and observes them again to help them refine. So always, that should never be a point where they feel like, oh, I've learned everything I can from this setting. It should always be a continually challenging experience. Excuse me. So the mentor, I like some of these definitions. I just pulled them out of the dictionary. But when they transition from being a student to a practicing clinician, that's when that relationship changes. So really no longer a clinical instructor, but more of a mentoring experience or relationship. So an experienced and trusted person who gives another person advice and help, especially related to work or school, over a period of time. And that's why I think what might be a little different than a clinical instructor relationship. It depends on, sometimes people just click with each other, and it can turn into a mentoring experience even in the pre-graduation phase. Wise and trusted counselor or teacher. And then I really like this last definition, someone who guides another to greater success. And I think that's what this is all about, to really help to guide to greater success. And it's not a supervisory role at this point. It's really a guiding mentoring. So here is just, excuse me, some effective characteristics of both clinical instructor and mentor. And then there's obviously a lot of overlap between both of these roles. But the clinical instructor needs to be a good communicator, needs to be able to facilitate clinical reasoning, clinical decision-making, provide effective feedback, learning opportunities. Also, an important piece is really orienting them to the facility, to the culture of the facility, and introducing people. Did somebody have a question, or is that was, sorry. And then, again, developing that entry-level clinician. The mentor is really someone who has enough clinical expertise to really share that. And so we'll talk about what our recommendations for the mentor will be, but we would like the more advanced clinician to take on the role of the mentor, someone who has advanced clinical decision-making themselves, who has open communication, is able to give constructive criticism and is comfortable with that, really develops a relationship with the mentee, and that can take on different forms depending on who the mentor and mentee is. Has some skill at facilitating reflection, helps the intern to identify opportunities for learning, and helps to develop their colleague in lifelong learning, and really helps with that professional socialization. So those are the intangibles of it. It sounds silly, but sort of helping them learn the ropes of your facilities. That starts as a student, but then continues on as a new professional. And then you see that there's lots of overlap between CI and mentor. So these are recommended criteria. We're not making them mandatory, but as we build this program over the years, and we are able to work with sites and get input from you all as well, this may change over time. But what we recommend, and this is based on our experience in just observing clinical instructors and professional development over time, but in the pre-graduation phase, we're using the APTA's criteria so that the clinical instructor should have at least 1 year of clinical experience. We recommend that they have the APTA CI credentialing course at the basic level or equivalent. So there are other programs that, you may have in your facility some training programs for clinical instruction or education. And we really feel it's critical for them to have strong clinical reasoning and decision making, because we feel that that's just such a critical skill in today's healthcare world for our graduates to be able to develop and demonstrate. In the post-graduation phase, we'd like all of those criteria. Plus, we think it would be helpful if the mentor has supervised at least 2 full-time clinical experiences, and preferably with more advanced students, so they have a sense of what to expect of an advanced level student, or someone who's mentored staff. Evidence of ongoing professional development, so maybe they've gone on the track of clinical specialization, maybe they're trained either as a resident or fellowship, as a fellow, excuse me. They're active and participate in professional organizations such as the APTA or other, and there's lots of ways to demonstrate professional development, but so that they're really able to model that lifelong learning and continual growth. And then this is the mentor training. So for those of your staff who will be working with the interns, we'll recommend that they listen to this webinar if you guys find it helpful and have access to the tools that I'll share with you as we go along. So you can see that it doesn't necessarily have to be one person that's going to be a clinical instructor and mentor across the full year. And we think that that's probably not realistic. And we don't even know if that's the best plan anyway. If you have multiple mentors and or if they're rotating to different areas of your hospital and organization, clinics, etc., then I think it would be helpful to have one person that's kind of the go-to, who's kind of organizing, overseeing the whole internship, just so that they know who to go to if things aren't smooth, or just to make sure that there's good communication across the mentors. At UCH, that they accepted an intern in their inpatient and their outpatient department. And in the inpatient department, I think the intern in 6 months worked with about 5 different mentors. And although she enjoyed her time with each of those, it seemed a little disjointed. And so her recommendation was to have fewer mentors over longer periods of time to really, and I think that bodes to that development of a relationship over time. But we're leaving that flexible to each facility, because you know your staff, you know who would be good at the pre-graduation phase, who would be good at the post-graduation phase, and again, it may or may not be the same person. So let's just highlight a little characteristics of the mentoring relationship in terms of the roles. And once the intern has graduated, we really want them to drive the experience. At that point, we're hoping that they have an idea of where they want this internship to lead and have a vision, but that the mentor can help them get there. So the mentor's role is really to teach, to assess, to facilitate, to support, and to challenge. The mentee is really to learn with intention. So obviously, when we're in clinical practice, I know I still feel like I learn something new every day. So they're going to learn regardless. but the intention piece is really guiding it towards areas that they feel they want to develop in. Obviously, their role is to respond to the feedback that the mentor provides, to communicate, to be motivated for continual growth, and then also to take risks. And I do want to just reiterate that it is the intern's responsibility to drive the experience. So we'll talk about structure again, but if, let's say, you carve out time, the intern should be the one that kind of, with consult with the mentor, figure out how to best use that time. It's not the mentor running around and making sure that there's learning experiences scheduled. It's really the intern that drives that. So the additional expectations of the mentees. Hold on 1 second. I've lost my place here. Here we go. That they are able to clarify their interests and needs, that they are preparing themselves for their role in the relationship, being able to actively seek feedback. So again, it really is what the intern puts in is what they're going to get out. They need to be specific and receptive to feedback, and then also recognize the value and limits of the relationship. So really, we're hoping that they'll show appreciation for the time and the assistance that they get from their mentor. So again, these are the skill set that we're hoping the intern will develop across the year. Again, their clinical skills, reasoning, professionalism, the confidence in themselves and in their role as a professional physical therapist, efficiency and time management, teamwork and collaboration, so really understanding their role so that they can contribute to and learn from other team members, professional roles and responsibilities, and leadership skills. And we'll talk a little bit about this professional development plan, but these are the areas that we're going to ask the intern to target in developing specific goals and strategies to help them develop in these areas across the year. So we're going to transition into talking about structure. So before we do that, are there any questions about sort of the contrast between clinical instructor, mentor? I'm hoping that you're thinking about people or maybe you've already identified people within your sites that will be working with the intern.
We have the clinical coordinator position for the one who takes care of most of our students. So she's the logical choice to be the person to go to for the student or the mentee. But she's pretty much embedded in our inpatient program. So like you said, it's going to be a village trying to get the person through the program,
right?
And making sure that there's others involved, and there's nothing said really that the person, after they get through with the first 4 months or so, that they wouldn't be able to be traveling between sites. I mean, like satellite clinics and so on. I know that Courtney has 4 or 5 sites, and I have 3 sites that person could at least get experience in.
Absolutely. So what UCH did, what they're going to do is for the outpatient, so they have an intern going on inpatient and an intern going in outpatient, and based on the pilot, what they're going to do in inpatient is rotate them between 3 different services. So they'll be 4 months at each service because they feel like 4 months is a good amount of time to get to that place where they can actually contribute and be productive. So obviously in the pre-graduation phase, that's going to be the least productive. But in the post-graduation phase, they should be able to acclimate quicker and be able to really contribute and then rotating to a third site. You can decide how many rotations, if you want to do it that way, you want to do. It just will, you want to consider, kind of balance that breadth of experience that you're providing with their ability to contribute and meet productivity because they are being paid. So in the inpatient,
It's just nice to hear what you're saying as far as, what has worked in other areas.
Yeah. So
what's been the most efficient.
Yeah. So in their inpatient, they're going to rotate. They're going to start them in inpatient rehab. Then they're going to rotate them to a sort of a step down unit in their med surge ICU step down. And then they're going to do, and I can't remember the exact order, but they're going to do another area of acute care. They decided not to put the student in the ICU, which I wish they would, because I think they need that mentoring in the ICU, but that's just what they've decided will work best for them. And then their outpatient, they're going to be at 3 different outpatient clinics. They'll be at the hospital-based one to start with, and that's going to be outpatient ortho. Kind of we're a level 1 trauma hospital, so in their outpatient department they see quite complex people. It's not like a straight orthopedic, and I'm sure in the rural practice you guys have the same, where you're seeing a variety of people. Then they'll rotate to another clinic that's off-site, where they'll get a focus on outpatient neuro, and then they'll rotate to another clinic where there'll be a focus on sports medicine. So they've decided these 3-4 months, and then they'll revisit after this and see if that works well. But they think that 4 months would be a good amount of time. Now, the other thing you could consider, because I don't know how this works, if you have, I think, Courtney, you shared with me, you have some staff that go some days to one clinic, some days to another.
Yes.
That would be another way of structuring the experience, that you could have them over the, in the first 4 months doing something, and then the last 8 months, maybe 2 days a week one place, 3 days a week another, or whatever. So it's kind of balancing what your needs are for this additional sort of staff person, and what you'd like them to, how they can learn best in your environment.
Can I just kind of think out loud with you and Steve
please.
for a moment?
That's what this is about.
So after talking with the potential interns yesterday, thinking of just kind of what our needs will look like, and obviously trying to run things efficiently from a business perspective, my thoughts maybe have changed a little bit versus when you were here.
Uh-huh.
And thinking maybe the first 3 months of doing, the inpatient rotation, which would be acute, skilled, ICU, step down, neuro rehab, acute neuro rehab. It's all kind of lumped together in our rural community health system here. But and then the last month maybe doing outpatient, and then not treating like a true float. As you kind of alluded to, we do have some people that float or rotate between clinics, but then plugging them in to the outpatient side of things. So my thought process was that last month, all of our outpatient clinics or satellite clinics do things the same as far as documentation, billing, all those aspects. So essentially at the end of the 4 months, if we needed to use them, in our Camdenton facility that has a quad, like we talked about, I want to get them experience with all of our specialties, but at the end of the 4 months and the beginning of the postgraduate or, paid internship phase, they would be able to go anywhere and kind of fill in anywhere needed.
Right.
Makes sense.
Yeah. And what I would say though, is that there would still be an assigned mentor. So if they're going to be going to multiple clinics, the potential challenge would be, but you could solve this by blocking off time. But you don't want them to just all of a sudden then just be focused on only the patient care. We want to carve out that time for the mentoring. So as long as you're able to identify a mentor or mentors that this intern would have access to across those different settings, or clinics, I should say, then I think it could work.
Okay, and I mean,
it seems like you have a nice team, even though they're spread out amongst the different clinics. And I think, Steve, you have this as well. There
Yes.
still is, I got the sense that there's still a strong sense of team.
yeah, I think so, and that's kind of what I would do. You know, I would assign them an overall mentor, and then there would be leads at each clinic that they would be with for any questions, and then kind of floating back to the postgraduate and some of those intangibles. They're going to need to know that, you know, there is a chain of command, and if you're uncomfortable with something, I mean, that's part of the learning process. Is you go to that clinic manager, and if you don't get the answer you want or think is appropriate, then you go to your mentor, and then, you know, ultimately to the director of the whole operation. So
right, and I love that it sounds like you would make that very explicit, which I think would be very helpful to the intern.
Absolutely.
Yeah. So what makes this a little unique is that they essentially are employees at that point. And so you don't have to create this whole new system for this individual. They're going to fit into your employee structure, even though it's a unique opportunity or a unique position, if you will. They're still, you know, you have systems in place to onboard, I don't even know if that's the right word, new employees. And so,
I like that.
So that these individuals will participate in that process as well. You don't have to have a separate process just for the interns. And we'll talk here in a minute about curriculum or structure, but I like your thinking, and I think my guess is it will continue to change over time, and it will probably be tweaked according to what intern you get, you know.
Sure.
But we want some structure in place so there is some consistency across all of our sites. But we know that it has to be flexible enough to work for the variety of sites we have, because we have, you know, some like yours, rural, within Colorado and out. We've got some very urban. We have private practice that's one freestanding site. You know, we have long-term care facility. So it has to be flexible to meet the needs and, you know, highlight the opportunities in each of those different settings for the interns.
Perfect.
Okay, great. So, you know, structuring the internship, another way to describe this is a curriculum, which really is you have goals and objectives, you have learning experiences, you have ways to assess, and, you know, the person going through should naturally develop. So what you're going to think about in developing a structure is, again, practice. Clinical practice is going to be a big bulk of that. But you also want to consider outside of clinical practice what learning activities you would want the intern to participate in, learning environment, the learning environment you have, and then the resources that you have. It will be helpful for the intern if you can have somewhat of a vision for the experience, knowing that it will need to be flexible and that it could change, because a lot can happen in a year, as you all know. And so even at the beginning of the pre-graduation phase, you might kind of have a vision for how it's going to go over the year. And then, like you said, you may have a staffing change that makes it that you have to change it. But I think keeping in mind that having a vision will be helpful for the intern. Majority of their time will be spent seeing patients because they need that practice. But then you both have unique resources available to you to, really be available to the intern as well. And the professional development plan, I'll talk about that in a minute, but that should really help to drive the curriculum, and I'll be sharing with how that might look. So when you create the structure for your individual facility, you're really going to determine how much time do we want the intern to be participating in direct patient care, and then block out time for non-direct patient care. And again, to share what UCH did, University of Colorado Hospital, they carved out 4 hours per week for non-direct patient care activities. We got very positive feedback from the interns as well as the mentors, supervisors that were involved, that 4 hours seemed to be a good amount of time for this. The non-direct patient care activities included time with the mentor, and again, that could be discussion. It could be, like you said, Steve, pulling the intern into, working with or exposing them to a patient that's very unique, or maybe something that you want to focus on with the intern, one of the goals that the intern had. It could be looking information up. It could be attending rounds. It could be participating in community outreach activities, or I know that when I was visiting the lake, Kevin was doing the joint camp. That could be something that the intern could participate in. What UCH did is that they also purchased a subscription to MedBridge. I don't know if you've heard of MedBridge, but it's an online continuing education resource. And they selected specific courses that they wanted the interns to take based on the types of patients that they were working with. This was just one of their, benefits, if you will. But that's, if you have internal rehab visions, continuing education opportunities, you might consider whether or not that's something you want the intern to participate in. It could be, again, then they also did a project, and the feedback was, and they were only there for 6 months, but the feedback was the project was probably the least beneficial in terms of learning, and the other activities seemed to be more beneficial. The interns identified the time with their mentor as the most beneficial time, which doesn't surprise me. So that is, again, something to consider, and how you're going to make sure that the intern has access to the mentor. I already talked about making sure that you encourage the interns to not use this time to try to catch up on their documentation or to fit in another patient, because that's going to kind of take away from the structure of the experience. But UCH did expect the interns to do some work on their own time. So they didn't feel like the 4 hours carved time should be all inclusive of what a new grad might do to prepare for a day, for example, or looking up information or doing work outside. So between mentor and mentee, they may identify certain activities that they think would be very beneficial, and it's okay to expect them to work outside of the typical business hours that you would expect. So the professional development plan, they found this to be really useful. Of course, we had them fill this out at the very beginning of their experience, and neither of these interns did a pre-graduation internship with UCH, so they were very new to the facility, and they had no clue of how to develop this professional development plan going into the experience. But what I think will help in our, a new model, initially I was thinking they could do this at the beginning of the internship, but now I think it makes sense that this would be done sort of in that transition from when they're in the pre-graduation to the post-graduation phase. And this would be a great mechanism to sort of do a handoff if the clinical instructor and mentor are different. So this would be sort of kind of sharing their development in the pre-graduation phase and planning ahead to the future. And so you might even think about whether it's your student coordinator, the clinical coordinator, the CCCE. So I know that's Kevin for you, Courtney. And I don't know if I met the woman who coordinates students when I was out there, Steve.
Lori Paulson?
I'm not sure if I met Lori or not, but it would make sense that maybe Lori and Kevin would be involved in this transition if they're not indeed the mentor themselves.
Yes.
But where they kind of identify goals together, strategies and resources needed. And again, this should come from the intern, but they would probably appreciate collaboration with their clinical instructor and mentor. So these are the target areas: the clinical skills, professionalism, self-efficacy and confidence, efficiency and time management, teamwork and collaboration, and leadership. And we would not, I mean, it may be that they break these up. So in the beginning transition, when they're in that newly graduated license phase, they're focusing more on their clinical skills and their efficiency and time management and their confidence. And then as they move through the year, they develop goals in all of the areas. So that'll just depend on the intern. But we think that this will be a great tool to help them on their path for professional development. So so I wanted to stop there to see if you had additional questions about structuring the experience. It sounds like both of you have kind of your wheels turning on what this might look like, but please, this would be a great time to continue to talk if you have questions about that before we talk about the specific tools.
I feel like I've got a pretty good understanding, and you and I talked a little bit kind of as we traveled around here, and Bill and I have talked some too, and I think I have a general roadmap laid out, and we'll be agile as things come up, which we know they will within the course of a year.
Yeah. Mm-hmm. How about you, Steve? Do you have some ideas of what the structure might look like in Aberdeen?
Well, yeah, I guess I need to probably avoid the tendency to have them go too many places, do too many things, and be a little bit more careful to make sure that it's consistent. At the end of their year-long internship, I certainly don't want them to feel like they've just had a conglomeration of week-long episodes here or there.
Yeah, I love that thought because, and I think that tendency is there because both of you have so much to offer. Your experiences are so rich, and those opportunities are just really great, which are attractive. But I love your thought. Really the beauty of an internship is that they will be able to dive in deeper and really develop versus just a smattering of here, there, everywhere. Now, one thing you might think about if you really want them to have exposure without expecting them to get to the place where they're proficient and contributing is in that non-patient care time, so that 4 hours a week. Another model to consider would be sort of they're based in 1, 2, or 3 areas, but then in some of those times they spend time with other aspects, whether it be the pediatric therapist or, other specialists, rehab specialists that you have there, speech, whatever. And they use some of that non-direct patient care time to get some of that breadth, but then their direct patient care time is more grounded. So that's another way to think about it. And, like I said, you don't have to have it clearly developed. It will be, working with the intern to kind of define what that will look like too. And so in the pre-graduation phase, at certain points, or especially in the second half of the experience or even that last month, might be a good time because I know you need lead time to schedule things, but that might be a good time to really nail it down and have a more clear vision of the experience. Does that help?
It's a new experience, so it's interesting, and I think we'll need to work both sides. I mean, the students are going to have to work hard, and we're certainly going to have to change our organization a little bit to make sure that they get a good and possibly a much better experience than we've been providing our students up to now.
Yeah. Well, I'm sure that your students have had excellent experiences, but what we're trying to do with the internship, and actually with all of our clinical experiences, is to have more consistency across sites. That's why we like to work with fewer numbers and really be a support too, so that and really collaborate with the clinics to develop over time. So I agree with you in this first year, and we saw it with the application process. We're all learning, and there's going to be little blips, and hopefully things will go smoother next year. But and that will happen. We're learning this first year, so it'll be a rich time for discussion and assessing how everything goes.
Absolutely.
So what I did is put together some tools that we think will help the mentors as well as the interns to facilitate professional development over time. And we're really targeting on 3 areas that we think are critical in this developmental process. So the clinical reasoning piece, the professionalism piece, which, as you know, with our changing healthcare environment and just the demands of the system, and really wanting to promote that patient-centered care, which I know is a value of Rehab Visions, and also the utmost professionalism that that's an area that we want to focus on, and then the reflection piece, because that really turns an experience into learning. And so I've put together some tools, and I'm going to highlight those here with you two. You're not going to become experts in these, but I just want to share with you the purpose of them, familiarize yourself with them, and then, if we need additional dialogue about it, or, as I think the experiences unfold, we can work together to see how useful these tools are. But I'll just share those with you now. So for the clinical, let me just back up. Whoops, I'm going the wrong way. Here we go. So one of the things that I think is really critical, and this has been found in the literature as well, is that the clinical instructor and mentor are able to articulate their own reasoning process. And I think that it is hard for experts. So your experienced staff, because they're working, they go through so many steps very quickly in their heads and get from point A to Z very quickly and are able to skip steps. Sometimes it's difficult for the student intern to be able to see what that reasoning process is. And so what we recommend is that you really practice articulating what you're doing, why you're doing it. And that's not that easy. Sometimes you have to really think about it to be able to articulate it. But that is really helpful for a student, and will be for the intern, to be able to develop their own clinical reasoning skills. And the credentialing courses, specifically the second one, the advanced one, there's a whole section on this, different models of clinical reasoning and mechanisms of helping experienced clinicians to be able to do that more effectively with their students. This is an ICF reasoning worksheet, and I don't know, are you familiar with the ICF classification, which is the International Classification of Function? This is out of the World Health Organization. And are you familiar with the NAGI model of disability where you're looking at impairments, functional limitations, and disability. Does that sound familiar?
I don't use it, but it sounds familiar.
Yeah, you may not use it, but you may not use that terminology, but my guess is that most, clinicians use this in organizing their knowledge and helping them with decision making.
But that's one of the basic reasons that I really like to work with students, is the fact that being older, I don't often, they've changed the scope of physical therapy so much over the time that some of the stuff that you guys are teaching them debunk anything I learned previously. So.
Right. Yeah. Well, it doesn't totally debunk it, and your clinical experience is so helpful in mentoring the younger therapists. But I'm in the same boat. I graduated with a bachelor's degree, and things have changed tremendously since I have gotten out of school. But we use this with our students in the classroom setting, and so they will be very familiar with this. But their ability to apply it in the clinical setting sometimes needs some help by the mentor. And I think this has a front and a back page. But basically, and actually, there's a great resource, a very short, free module through the APTA that we have links to on our website for clinical instructors to kind of familiarize you with the ICF model. But one of the things we really like about the model is it provides a framework for students who don't really know how to organize all that knowledge that's in their head. And it gives them a framework to be able to do that. And so basically it looks at different levels of impact that a disease or a condition or an injury has on an individual's life. And by breaking it down in that way, it helps the student to better understand the individual, the impact of the disease, and how they might be able to help the patient. So it takes the health condition, so it could be a disease like Parkinson's disease, or it could be an injury like someone who's fractured femur. And it then looks at how does this impact this individual's life? So maybe they're not able to work any longer because of this condition. And then it breaks it down into, okay, why aren't they able to work? Well, they're not able to do, let's say they can't walk far distances, or they can't sit without pain. And then they're able to break it down even further to, okay, why can't they sit, or why can't they walk? And they look at the impairments of body structure and function. So that could be weakness, or lack of coordination, or balance impairment, or pain. And then they also take into account the personal factors and environmental factors that may have an impact. And those are critical when we're thinking about patient-centered care. And so by breaking it down and making the linkages, then the students can better understand, okay, from a physical therapist standpoint, what am I able to do to impact this patient's condition? What's their prognosis going to be? And the nice thing about this framework is it's not discipline specific. So a speech pathologist could use this, a physician could use this, and it just helps with common language. But this is one of the things we use in the classroom, and that can be easily translated into the clinic. The second thing, we developed my approach to try to facilitate clinical reasoning. And this was developed by one of our faculty, Denise Stelzner. And the nice thing about this is it breaks down the information, data points, I guess. So from the referral to history, physical exam, plan of care, and intervention. And it helps the CI or mentor facilitate the student in bringing the knowledge that they have forward and helping them develop hypotheses to help come up with what they think the problems are and what additional information they might need and how they might be able to, what tests and measures to select, how do you interpret that data to know what to do. And what she has done is sort of map this out so that the student kind of knows that they're going to bring whatever knowledge they have of the pathology forward. And then it identifies some specific questions that the CI can use to help get the dialogue going and facilitate the student's reasoning. So we found this to be very helpful. And you don't have to use the whole thing, but it's also helpful in identifying where there might be a breakdown. Where is the student's thought process breaking down? And so then you can just focus on that area as well. And again, all of these tools are posted on our website for you to look at more in detail. Now,
What is your website again?
It's, you know what, let me grab that so I can tell it to you, but I think it's on the end of this webinar too. But
Oh, it is. Okay.
Yeah, but that's okay. You can go to our website. So www.cuphysicaltherapy.org/ClinEd. And then once you're in that website, then it'll ask you for a password. And the password is ClinEd, CLINED.
Great. Thank you.
You're welcome. And you're welcome to look at anything that's on that website. We do have a page that says resources for year-long internship and CE3. And that's where this information is held. But we have some, if you click on the Learn Now section, there are some other resources that you may find helpful as well about evidence-based practice and outcomes and things like that.
Great.
Yeah. Okay, so after Denise developed that, something very similar was published in the literature. And this is something that UCH used. And it's actually a more detailed and it's more elaborated than what Denise put together. And they found it to be very helpful, although they did find it to be a little bit cumbersome. And so because there's lists and lists of sample questions. So what they ended up doing, and the interns found this to be helpful, is the intern sort of drove the session. So the intern decided, I really want to focus on prognosis with this patient. And so they really focused on that piece of it. This article is posted on our website, and there are addendums that have the specific questions that a CI or mentor might use to facilitate the reasoning. And again, it also helps to facilitate the reflection piece as well. And it can be daunting to look at as a whole document, but you can, again, pick and choose, just focus on a little bit. If the intern says, oh, I really am having trouble, picking out the appropriate tests and measures. So you might focus on that piece of it. But at UCH, they actually use this when they did a collaborative session, like if the mentor and the mentor watched the intern do an initial examination. Then they use some of these questions to facilitate a dialogue afterwards to take the intern to a deeper level of thinking. Does that make sense?
Yes.
Okay.
Yeah, I like it.
Great. So this is one of the addendums that you'll have access to. But so, for example, after the initial data gathering, the interview, the history, these are the reflection points that the CI and student might look at together. Then they generate an initial hypothesis, and then there's more reflection points. So they found it to be very helpful in also not only they're developing their reasoning, but being able to articulate the reasoning and then being able to articulate it in a more concise way. Another tool, and this is part of the CI credentialing class, the advanced course, and I'll play this for you in a minute. But this is really to get at the time it takes to try to facilitate clinical reasoning. And this is a mechanism that came out of the family medicine residents literature. and it's really, they call it micro skills for teaching. And like I said, it's covered in the advanced CI course, but there's steps within here that you'll be able to see this encounter here in a minute, where the mentor or clinical instructor tries to get a commitment from the student. They probe for supporting evidence. They teach general rules, reinforce what was correct, and then correct any mistakes. It's called a 1-minute CI. It takes about 5 minutes, but it's focusing on the CI doing less of the talking and the student or intern doing more of the talking. So again, the goal is to move students to a deeper level of thinking and to help them synthesize and evaluate their knowledge. So I'm going to go ahead and click on this, and you can watch it here. Hopefully. Here we go. Can you guys see it?
Coming up.
Okay, good.
Try improving your teaching skills with this classic 1-minute preceptor technique.
No, I guess not. It's just
Yeah, I'm unable to see it either.
Oh, you can't see it either?
they just kind of blocked out the screen, but I can hear something, but I can't see it.
Okay, let me pause it because Blake just came in to help me.
What would we do without the Blakes in the world?
Yeah.
I couldn't function. I love my Blake. I've got a lot of supportive people around me though that I couldn't function without.
How's that?
Here you go.
Okay, perfect. Thank you, Blake. All right, so we'll start it over. You guys can see it now?
Okay.
Yes, ma'am.
Okay, perfect.
Try improving your teaching skills with this classic 1-minute preceptor technique. So, what have you got there?
This is a 45-year-old woman who fell down 3 steps, and she landed on her right elbow that she can. She has some pain and swelling over the lateral part of her elbow. When I examined her, I was looking over her elbow flexion above her knee, and she pain was
Okay, so what do you think is going on here?
I think she just has a simple sprain of her elbow.
Okay. Did you think about anything more serious?
Well, I looked at her fracture on the x-ray, and I didn't see any fractures of the elbow or the wrist. And when I palpated over her snap block, she didn't have any pain or tenderness, so I think it's a deep fracture is quite unlikely.
What we'll do is we'll go and take a look at the x-rays. And when we do, I want you to take a good look at the lateral view of the elbow and look for a sail sign. You see that when the fat pad's elevated by intra-articular hemorrhage. And that sometimes can be the only sign of an occult radial head fracture. So, let's go take a look. You were right to think the fracture came with that mechanism of injury. But I think with the lack of tenderness and the normal x-ray, I think that's good now. But I do think she probably does have a fractured radial head. If you look at this sail sign here, you can see the elevated fat pad. And even though we can't see a fracture on the radial head itself, we can infer it from the secret. So I think we should treat her for that. Okay, so we'll go back and see her. Sure.
So, I mean, that's a very, oops, sorry. Let me see if I know how to get out of here. Here he comes. Thank you.
You going back to the presentation?
Yes, please.
This one? That's the video.
That one. Perfect. Okay. So obviously this would take practice to be proficient at it, but I think that the whole idea of pointed questions and again, really trying to elicit the information from the intern versus doing too much teaching and really focusing on, one aspect. Does that make sense?
Yes.
Yes.
Okay, so we're kind of transitioning into tools that you might use to facilitate professionalism. And I don't know if you're familiar with this generic professional behaviors. Have you ever seen this from any of the programs from students that you, from students from other programs that you take?
Yes, I have.
Okay, excellent. So this is something we use in our program, but the nice thing about this is that they have been incorporated into the CPI, so you don't necessarily have to do a separate assessment of these, but there is what I find them to be very useful in is if you are experiencing, like if you're seeing some deficits, it helps to be able to label it, to be able to talk to the student or intern about it. I mean, you probably use this with your employees as well when there might be an issue in professionalism. And the tool that we've posted has a definition for each of these behaviors, but it also has objective behavioral criteria so that you're taking the focus away from the individual and focusing on the behavior. And there's levels: beginning, developing, entry level, and beyond entry level. So it's a way that the intern might be able to frame their goals around professionalism by looking at some of the description of beyond entry level as they're moving into the internship phase. It also, I think, I've used it when in giving feedback. It sort of gives you verbiage to use that is more objective than, and I found that then students are potentially less defensive when receiving this type of feedback. And so I'm sorry I didn't advance this enough, but here's one of the behaviors is critical thinking, and you can see kind of the beginning level, intermediate, entry, and post-entry level. What we use in our program is we say that students should be demonstrating the criteria at the beginning level before they go out on their first clinical experience, which happens at the end of year one, that they should be demonstrating the intermediate level in year two of the program, particularly when they go into their second clinical, and they should be at entry level by the time they graduate. And then now with the internship, they potentially could be at the post-entry level for each of these 10 skills by the end of the year-long internship. The other thing that we can use to help interns and students develop in professionalism is the APTA core values. And the thing that I like about this is that there is a self-assessment tool, and what it does for each of the 7 core values, it identifies the value, which would be, in this example, would be accountability. There's a nice definition, some sample indicators, and then the intern or student can self-assess each of these behaviors to say, am I demonstrating this ever, rarely, occasionally, frequently, or always? And then they can set goals around this. So I think the other nice thing about these tools is when they're trying to sit down and write a goal around professionalism, it may not be that they're not professional, but that they want to grow in this area. And these tools can help to objectify it, if you will. So in terms of promoting reflection, and you can obviously use questions to promote clinical reasoning, to promote professional development, as well as reflection. I think using guiding questions, I'm sorry, my phone's ringing, so I'm just going to let that ring, so sorry about that. You can use guiding questions in order to facilitate each of these key areas. And I borrowed this from a colleague of mine who adapted it from Adam's Change Your Questions, Change Your Life. But what I really like is this looking at the way that we ask questions and how we can really facilitate versus sort of demean, I guess. And we want to move out of the judging role and more into the facilitating the learner role. So these are just kind of some great examples of, instead of saying what went wrong, we might say what worked. And you could say, what would you have done differently? And that seems different than what went wrong. What'd you do wrong? Why is this a problem? And so it just, I think, reiterates to me the importance of language choice when communicating with anybody, really, but with our students and interns. And again, we're trying to use questions to move them along that continuum of novice towards expert practitioner. So other mechanisms of reflection, we have a couple that we use even during our clinical experiences, not even thinking about the year-long internship. But this, we have a couple weekly planning forms, and this is one that we adapted with permission from the Texas Institute of Rehab and Research. They're one of our clinical sites, and they have developed this for their clinical education program. It's a student feedback form, and one of the things I like about it is, as you know, sometimes it's hard to verbalize, and particularly for students, because there's that power differential, to verbalize any concerns that they might have. And this really helps to open up the communication by sharing it in writing. Even if an experience is going extremely well, you might hear different feedback in writing versus in verbally. So it gives the opportunity to develop goals on a weekly basis, but also gives the CI feedback, which I know CIs always want feedback, and many times students are reluctant to provide it. So I think this can be an excellent mechanism for that. Another mechanism for promoting reflection is journaling, or having students write a narrative about an experience that they've had. And, it can be a tool for those individuals who aren't naturally reflective. There are people who just are naturally, they tend to be more self-reflective than others. And again, journaling can help a student process and take an experience to a deeper level of learning. And we have students do, we don't call it journaling, but it's a guided reflection on each of their clinical experiences, and where we just pose a few guiding questions and then allow them to respond based on an experience that they've had. So those are just some tools. There's many more out there, but ones that we have found to be useful. And I know that just by presenting them to you, that doesn't necessarily help you to be able to implement them in a proficient way. But I think we can be a resource for you if you have questions or want to try to implement any of those tools. One thing that will help us all stay on track is, and making sure that the student and interns are on track, is the use of performance measures. So in the pre-graduation phase, we recommend that we planning forms. That helps open up communication and keep students on track where they're doing weekly goals. The second thing is we have monthly benchmarks we've used monthly benchmarks for our 4-month clinicals for the past several years, and we found these to be really helpful. So you'll receive those when the student comes, but it just helps to, in these longer experiences, to make sure that the student is on track. And if they're not meeting these monthly benchmarks, it's not that they're punished, but it helps to for the school to kind of get involved and maybe identify a more specific plan to help the student get on track and make sure that they reach that entry level. And then of course we use the clinical performance instrument, and we ask that the CIs complete that at the midterm and the final. In the post-graduation phase, we are using the professional development plan to frame and guide and determine whether or not students are on track to meet what they want to get out of the internship. And then we recommend that you would use your employee performance appraisal, whatever you use with new employees, we recommend that you use that with the interns as well. And the feedback we got from the interns is that they really appreciated the opportunity to have a sit-down meeting with the rehab director to discuss their progress, their goals, their future plans. And so that was really empowering to them. And they didn't really anticipate that they'd get to meet with the rehab manager to be able to do that. So you can determine like who would do that. The professional development plan would be discussed with the mentor. So intern and mentor kind of doing that. And then I don't know if you have probationary period or what your cycle of doing performance appraisals are. Is it the same across Rehab Vision, or is it?
Yes, we do them in March every year.
In March. And then do you do for new employees, do you do any, is there like a probationary period, or do you do, or
we don't have a probationary period. At 90 days, the home office does call the employee though and to see if they have any questions.
Okay, so at 9, so
I know, Courtney, do you do a 90-day?
Yeah, just through home office. I think it's a formal. I think they have a formal process for the follow up, but there's no probationary period.
Mm-hmm.
Yeah.
So with the interns, they'll graduate in December. There may be a little gap before they start, in the licensed phase. But that would be like, let's say January, February, March. So it might fall right within your employee performance appraisal cycle.
Sure.
Right.
And then what would be interesting is March, April. So, and then they will finish in August. So I don't know if you'd want to consider doing sort of, a checkout or I don't know what you'd even call it, but a final kind of debriefing or something at the end of the experience. And that can be determined, to be determined at this point. But it's something to consider, and we may even have some suggestions at that point.
But as it is right now, you don't want us to use our own performance appraisal.
No, I would like you to. Yes.
Yeah.
Yes, exactly.
Yeah, that's what I meant. I'm sorry.
Yes, no, that's okay.
Then Courtney's and mine or whoever would be doing it would be all the same.
Yeah, I think that would be excellent. Yep.
Yeah.
Mm-hmm. So that's all I had, and just to summarize kind of where we are in the process. As you know, you went through the interviews, and Steve, were you ever able to connect with Jamie?
Which one?
Jamie, who was the
I have called her a couple of times, and I think she's not available even today yet.
Correct.
If it's okay, I'll keep on trying.
Yeah, no, it would be great. And what I will do is I will also send her an email that kind of reiterates what you and I talked about in terms of if she has a time that matches with the time you have available next week, to be able to do that, so that you would be able to rank the interns have adequate time to rank the interns by the 13th. That would be great.
It would have been nice if I could have met him, but
Yes,
I guess even well, we'll keep trying.
Yeah, I think if you can do the Skype interviews like we talked about, I think that would be great.
Okay.
For both, yeah.
Thank you.
And then the Clinet team will do them, and as you know, the students will be ranking the sites that they interviewed at, using the same process you will be. And then we'll do the match at the end of June. So you will hear by the end of June. The internship starts this year, August 29th, and they will finish, I say December 16th, but it's really December 13th. You'll get, if you get a match, you will get a confirmation letter and all of that, just like we do with our clinical experiences. And then the post-graduation phase will continue through August of 2017. So the next steps, which I think Deb has already done this for Rehab Visions, that we already have an addendum to our contract. But the other thing I wanted to just share with you is that even in the post-graduation phase, we want to continue to be a resource for you. So, in the pre-graduation phase, we'll treat it just like we do with our other clinical experiences. But in the post-graduation phase, we want to have communication, and I don't know, maybe we'll even try to do a phone conference or something midway to see how things are going with everybody. I don't know. But if you have ideas of what would be helpful, please let me know. And also don't hesitate to contact me if questions come up, because we're building it together. So, but that's all I have. Do you guys have other questions?
I can't think of anything right now. You're very thorough. Thank you.
You're
The
so
only thing
welcome.
I guess, so in the postgraduate phase of this, if there are, and I can't foresee that this would happen with either of the two people I just talked to yesterday, but I guess we treat them like employees if there's a disciplinary issue or a.
That is correct.
But then then we communicate that with you, or?
Well, you know what's interesting? Somebody shared, maybe it was you, Courtney, who said that because of confidentiality, you wouldn't be able to share that with me because it's an employee.
Oh, okay.
So I don't know. I will ask Donna Applebaum from MGH Institute how that's handled. What the role of the school or the support that the school can provide. And like you said, hopefully if issues were to come up, they would have surfaced in the pre-graduation phase and have been resolved by that point. But you just, as you say, you never know.
Right.
But I will ask Donna about that of the legalities, as well as, aside from the legalities, how she's continued to be supportive of the sites in the post-graduation phase.
Now, just a thought.
Yeah, no, right. No, I think it's good for you to be thinking all of these things. And I know we can't anticipate everything. And I know the what ifs, sometimes you don't know what to do in the what ifs until they occur. But, just I want to reinforce that if you have issues, we're not going to abandon you. We really want to build this program together.
No, it sounds good. Thank you.
Happy to do that.
Well, excellent. Well, thank you both for spending the time. And Blake is going to help me edit this so that we kind of take off the stuff in the beginning that they don't need to hear.
Yeah.
And you'll have access to it, and you can, if you think it's helpful, share it with whoever you want to at Rehab Visions.
Okay. Thank you.
And we might be using it for our other sites as well. So.
All right.
Perfect.
All right.
Sounds
Thank
good.
you so much. If other questions come up, don't hesitate to email me. Okay.
All
Will
right.
do. Thanks,
All right.
Jenny.
Thank you again.
Thank you.
Okay. Have
Bye-bye.
a great weekend. Okay.
Bye-bye.
Bye. So then do I say leave meeting?
Yeah, I would stop sharing.
Mm-hmm.